I have a webcam now.
I'm sorry?
I have a webcam now. I just realized that.
I see that. That's like amazing. So don't go away. I'm excited to see your face. And I hear you're going to come down to LA. So that's awesome.
Yes, I'm really excited about that. Thank you for.
Yeah. Nicole, so Nicole, who's right underneath you, at least on my screen from Napa, we were there this last weekend. It was pretty amazing. So
that's what I heard from Jessica and Rosemary. They were really, really impressed.
Yeah. So
yes,
yeah, good. So welcome everybody. I think we'll go ahead and get started. And today I'm excited about this conversation. We have Catherine Johnson who's joining us, and there's been this work that's going on around health information exchanges, and I'm not sure how many of you are aware of it. So I thought it would be a nice time to share what's happening in this world. It's a pretty interesting vortex. You know, it's an interesting world, and I think that it's totally related to the work of the ACHs. Humboldt has actually been participating in this, but some of you are in geographic areas, you know, like LA, where it may be also relevant. So I think, you know, what I wanted her to do was to provide an overview, just have it to be a dialogue, and then possibly use this as an opportunity to hear from you, from those of you that are on the phone, about what your specific data needs are. I'm kind of in a space of gleaning from you and reflecting on what's really needed for next year. So thanks to those of you that have responded to the Lumio survey. It's been really interesting to see a lot of energy around resident engagement, a lot of interest there. This issue of data and data analytics, because it's one of the 7 elements, is an important piece. And as we're moving, you know, down the journey of your ACH development, it's just good to know kind of your thoughts and needs. So with that, I am going to turn it over to Catherine Johnson to take it away.
Okay. Could I just ask what areas are represented on the call? Like, where are you from?
So you have to take yourself off mute.
Geographically, you mean?
Yeah.
Yes, please.
Okay, Napa County.
Uh-huh.
Jessica and I are from Humboldt County. Hey, Catherine.
Are you there, Jessica?
Yep. Hi.
Hi.
Mary and I are from Riverside.
Riverside.
Justin Ammon from Lake County, California.
Great. Is that it? Okay. Well, thank you everybody for having me. So, you know, and Jessica, feel free to chime in. Jessica has been on this journey with me for since the inception, and it has been quite a journey. But essentially, health information exchange. You know, I'd love to do a Q&A, but I know with the mutes, it's hard. But I'm not sure how familiar you are with health information exchanges, and maybe even a more specific question is, do you know who your local health information exchange is? So maybe in Lake County, do you know who your HIE is?
I have not been in contact, so that would be no, but I'm sure I could find out.
But you know, do you know what it is? Do you know what a health information exchange is?
I'm assuming a data resource.
Got it. Okay. And Riverside?
No.
Okay. And how about Napa?
Sorry, no, I didn't even realize that we had a health information exchange.
Right. Okay. So first of all, a health information exchange is essentially a nonprofit organization that has established themselves as a kind of hub, if you will, for interoperability between healthcare providers in their area. And you know, in some places the area is just, it's smaller. It could be county level, it could be city level. Most often the ones that are kind of viable organizations are at least county level HIEs, but some of them do extend into other parts of the state. So essentially what they're doing is they are linking. So if you can imagine, let's say, for example, in Orange County, there are multiple hospital systems, and each of them have, you know, a provider network. They have information on the pharmacy data. They have information on procedure codes or diagnoses codes of patients that are going into that facility. And they have what's called a master patient index, which is a way that they identify the patients that are attending in that hospital. What an HIE does is it says, okay, hospital A and hospital B, we want for patients that go back and forth between your hospitals, we want to have improved efficiency in the clinical care so that when they show up for the first time in your hospital or for the fourth time in your hospital, you have a more comprehensive view of what's going on with that patient. And so what an HIE does from a technical perspective is it kind of blends all of the information through a portal. And it's, I mean, I don't need to get into the details, but they essentially query the different data sources, and they say, okay, Catherine Johnson has shown up in our emergency room. Who knows anything about her? And the organizations that are participating in that HIE would all get a kind of a query, and then information would be compiled on Catherine Johnson, and then the provider would have a more complete record. That's typically how the larger ones function. Some of the smaller ones work on a data repository, which means that they actually they're collecting and storing clinical information on the patients. That is less common because most hospitals don't want to send their data anyway, you know, anywhere. They want to keep their data and actually only receive queries for it. So essentially, that's what a health information exchange does. And it's been, you know, they've been functioning for the last, you know, 12 some years. I would say that of those places that are represented, I'm pretty sure Napa County, I think that Redwood MedNet is at least trying to be your HIE. I'm not sure if they have succeeded. Jessica, you may know that. But
I don't know offhand. That definitely seems like the right region, but I couldn't say
Yeah.
that with any certainty.
And
Yeah.
aren't they Lake too? It's Lake, right? I thought Redwood MedNet.
would also be covering, yeah, Lake
Yeah.
County. Mm-hmm.
Yeah.
Okay, it's Redwood.
Redwood MedNet, Will Ross is the CEO. And what I'll tell you a little bit about what's happening in terms of funding opportunity that might be of interest to you guys there. But let me finish kind of my explanation of what they are. So essentially, you have these health information exchanges that have been, you know, gradually growing for over a decade now, trying to be a meaningful resource for clinical information in their communities. And what we have been working on is trying to expand their data to include social determinants of health data. So again, typically right now, it's all clinical. So normally what you're going to get are lab reports, pharmacy data, discharge summaries, you know, but what we're trying to add are social determinants of health data, and we can talk about what that is. These are the participating HIEs that are in this initiative. It's Orange County. Sorry, I've got this thing that I'm trying to not see.
What do you trying not to See?
Yeah, there, just this panel, because I can't read. Okay, so, so here are the participants: Orange County ACPRIO, Los Angeles Lane, San Diego Health Connect, and Humboldt County Nichin. So these are the 4 HIEs that are participating in these discussions. And essentially, again, it's around creating, figuring out different models of how we could link social determinant data with clinical data. Again, here are the current activities. Right now, we're looking to secure the social determinants of health data sources. I'm not sure if folks in the northern part are familiar. I don't know if Riverside has a County 211 system, but down in the Southern California, there are large aggregators of social determinant data, County 211 data. Are folks familiar with that, what that source is? Has anyone heard of a County 211 system? Jessica, I know that you do.
We do. The Humboldt County 211 is definitely far less robust and less resourced than what you see with the CIE in San Diego. So oftentimes, I don't know if this is true for Nicole or Lake County, but it seems like United Way has provided traditionally in the northern half of the state sort of backbone support to 211. So it's possible there's a relationship there in your community.
Mm-hmm. Larry, you're in Riverside, right? Are you familiar with your 211? Okay.
Sorry, I'm having trouble with my controls. No, we're not involved. I think IEHP runs the Health Information Exchange, but they haven't engaged with us on that.
I think in Riverside, your big one is Manifest MedX, right?
I have no idea.
Yeah. So stay tuned on that, because I think you'll find it interesting to know, because there is funding that's hitting the HIEs in the state. So in any way, what we're working on is for each HIE, they have come up with their own mechanism to secure the social determinants of health information. And I've listed here what they're doing. I'll talk a little bit more about the assessment tool. And actually, Redwood MedNet should not be listed on this, so that's an error. So this is what our current activities are. We're finalizing the integration strategies and the budgets. We're integrating individual strategies into a comprehensive narrative that includes all of these HIEs, so that we have one comprehensive proposal that we're trying to pitch to the state on to secure funding to develop interfaces between the HIEs and the social determinant of health data sources. Just so that we're clear, I think all of you are familiar with what they are, but this is how we're defining social determinants. It's based on the IOM definition, and so these are some of the information that we're looking for. And then as I mentioned, we're exploring 3 integration models, basically. The first is developing interfaces between the HIEs and the aggregating entity within the county, i.e. the 211 programs. There's also in Humboldt, they're talking about doing direct interfaces with the county systems themselves. So the county systems that are, basically the source systems for the data, they're talking about doing direct interfacing and having a care coordination component on top of it. Another mechanism, and the last mechanism, is social determinant of health assessment tools. So right now, there are assessment tools that are typically taken at the point of care. And this is, it's like a questionnaire that an intake nurse would be asking to a patient, and they would say, do you have any trouble? Are you in any way concerned about food security? Or are you confident that you have a place to live, in the immediate long term? Or You know, do you have any violence at home? And so it's just a set of questions that they're asking, and they're typically on paper. And generally what happens is that they get scanned into a PDF and then they get uploaded into an EHR, and it kind of just sits there. A lot of times they are required by particular funders, like Medicaid has the Staying Health Assessment assessment tool. Prepare is another assessment tool that a lot of funders in the state have actually tried to rally around. These are different assessment tools with different sets of questions and formatting. They're all kind of trying to get to the same, you know, end goal though, of, you know, what else is going on in the patient's lives. So what we're trying to do is turn what is typically a PDF form, we're trying to turn it into a smart app that interfaces directly with the Health Information Exchange network, so that the data becomes queryable. So discrete fields that you could run reports against, and that you would actually be able to be provided at the point of care with the physician, so that the physician is able to look at the person who they're treating for asthma for the last 6 months and go, oh, okay, you're actually homeless and living under a bridge, and that might have something to do with the way that I'm going to be providing care and what we can reasonably expect. So it's the merging of, you know, getting a bigger picture for the patient. So these are the 3 ways that we're looking at how to integrate the data into and essentially combine the clinical and the social determinant data. I'm going to pause there and see if anyone has any questions or comments, and then I'm going to talk about some things that's happening at the state level around funding that's also going to be impacting HIEs. But are there any thoughts or questions here?
So Justin has a chat question about timeline. And I don't know if you're going to talk about that with the next piece, but.
Awesome. Love this tool. Okay, timeline. I'll get to that. Luckily, we have a new CHNA from dashboard that our HIE can access. Okay, so
Catherine, can I just add something? So just to go back to September, in September, I had Carolyn Fichtenberg from Siren give a presentation on a variety of different social determinants of health assessment tools. That's recorded. There is also some other information that I posted on the website related to those tools, Prepare being one of them. So just to kind of make the connection between a previous discussion and this.
Yeah, that's great. You know, the idea would be, let's survey, because, you know, the problem with social determinants of health data, and by the way, this was the same problem with clinical data, you know, 15 years ago, there's a lack of standardization. So, you know, in order for HIEs to basically be blending clinical data from different systems, they needed to come together to agree on a standard, so that providers would be able to interpret information from different systems effectively. The same has to happen with social determinants of health, and we literally are right at the beginning of that conversation. There are hundreds of assessment tools out there. Again, you know, they'll ask the same question, but in 5 different ways. And so it makes it really hard to have that data be interoperable. So because we can't solve that problem right away, what we're planning on doing is surveying the members of the HIEs and saying, and again, we're talking about the hospitals, the clinics, and saying, you know, what assessment tools are you using right now? And recognizing we can't get everybody to use the same assessment tool, we would start with some low-hanging fruit. And if we found that a bulk of them were using Prepare, for example, or SHA, then we would start with that assessment tool. And that's kind of how we're approaching the standardization issue. So in terms of timeline, so the funding that this group is pursuing is part of CMS funding. So CMS at the federal level has funding to support meaningful use. Meaningful use is all about essentially promoting interoperability at the provider level. So there's a lot of requirements that providers and actually hospitals have to do to achieve meaningful use, to either avoid penalties or receive subsidies from the feds. In addition to this kind of incentive program, there's a large granting program that is putting money into each state on expanding their interoperability within the healthcare system. In California, a group of organizations basically pooled their resources and secured funding. Well, I don't need to go into the mechanism, but essentially there's going to be $50 million that's coming into the state to support HIE expansion. And what that means is that the HIEs that are listed here, as well as some that are not listed here, are going to be eligible to receive funding that would improve or develop interfaces between their HIE and typically hospital systems. And so hospitals that are not yet connected to an HIE will be eligible for this funding. And I think it's relevant for you guys to know that, because I think if I were in your shoes, knowing that this funding is hitting, I would be looking for your local HIEs, who, by the way, are going to be pulling together proposals to pursue this funding, and just touch base with them and see what they're thinking. You know, how are they participating? What are their plans for securing some of the funding? Because that's funding that's going to be potentially hitting your communities and impacting some of the hospitals and the healthcare systems in your community. That timing is not too far away, actually. I think the funding is likely to hit in February, March. And so there should be kind of prep for proposals should be happening as early as January. Now, that's different than this. So the 50 million is basically the same funding source that we are trying to secure with this funding. So once the 50 million has hit the state, we are going to follow up and say, okay, in addition to connecting the hospitals to the HIEs, we want some of the CMS funding to go to expand into the social determinants of health. And so we are essentially putting in a bid to be second in line, if you will, after the 50 million. So the timing for that, it's unclear. I would think at the earliest we're talking about, say, September 2019, you know, fall 2019, to secure the funding, just because of the timeline that keeps getting pushed back with the feds. I know that's not kind of immediate, but that's where we are. Let me see what else I have here. So that's kind of the update on the program. And again, I can pause and ask if there are any questions or comments, but we also wanted to use this opportunity to talk to you about what your data needs are, and maybe some of the impact that you could see on having this data available for your work, and what can we do in the interim to help support you in your data needs. But I'll pause and see if there's any questions or comments.
And also, Jessica, I'm wondering anything else to add, just because you've been in it, that might be of value from an ACH perspective?
Yeah, it's interesting. I mean, I feel like I'm both wearing sort of so Ensign's name is the North Coast Health Improvement and Information Network. We actually started as a HIE in 2010, really focused on typical HIE-based business, so sort of data interoperability, you know, how do we send information across the care continuum? We're a repository model, so centralized model. And 3 years ago, we added the second I, which is for improvement and community health improvement activities. So I actually feel like there's sort of a confluence of both of those roles in this webinar. And it's interesting to sort of be at that intersection, because I think a lot of times in our ACH type of work, we are looking at data sources like community health assessments or community health needs assessments, sort of aggregate level data to sort of guide our strategic planning in our communities. And oftentimes we are looking at social determinant health data, but at a population level to think about, you know, where are the priorities in our community and where are our opportunities to address them. On the HIE side of the equation, we're often thinking about that data, but at an individual level for providing care. And so we're sort of in both of these spaces in this conversation. And so for us, I think we think about it more at the individual care level right now. And our focus for the ACH is substance use disorder. And so sort of wearing the HIE hat, we think about how can we collect some of that social determinant of health data around the folks with substance use disorder in our community to sort of, you know, meet their social determinant of health needs, stabilize them, so that we can also sort of positively affect or prevent or get them into treatment around substance use. So it's interesting. I think it's interesting to be in this conversation with this composition of people. So I guess I would be curious to know, my ACH colleagues, like, is this resonant? I mean, how are you thinking about individual care, individual sort of levels data in the context of your ACH for care delivery, those sorts of things?
Mm-hmm. Thanks, Jessica. Yeah, so I don't, you know, I see chats, you know, Justin, Nicole, others. Any responses to that?
Well, that sort of patient level shared data would be, it would be a great help here in Lake County, especially with the continuum of care, and we have transitional housing and various other wraparound services that we can't leverage when they go out of network, which is incidentally just across the lake.
Right.
Yeah. I saw the comment from Nicole too about sort of building her ACH around finding on social determinant of health needs. I think I can sort of share from experience in Humboldt that it's been really rich. So one of the data sources we've been able to integrate into our HIE is housing status. So is this person enrolled in permanent supportive housing? Are they not? And it's been rich experience and it's complex. I feel like each time we go after a new data source or a new data partner, there are a lot of regulatory considerations for us. And then thinking about the places where some of that data is housed in the community. So for example, at an NGO, a non-government organization, they have different regulatory guidelines than we do as a HIPAA compliant organization. So how they sign on to our participation agreement, which is essentially sort of the HIE speak for data use agreement. It's complex. It's really valuable and also a really complex space to be in.
Mm-hmm, mm-hmm.
Mm-hmm.
Well, you know, the thing that I really appreciate with you guys, Jessica, is it sounds like because you're in the data business of being an HIE, you're kind of you're savvy to how to apply that thinking to the ACH. And I guess my question that I'd ask the others is, in thinking about your data needs, you know, Jessica, you mentioned the community health needs assessment. I mean, what data sources are you folks looking at to move your strategies or to help define your strategies? And do you feel like you've got resource in that space?
And, or if I could just add, Catherine, like, have you even started, right? Like, I know a number of the sites, not all of them are in the midst of their community health needs assessment/assessment. Some are collaborating with the hospitals and some not. So I think, you know, maybe people are in different spaces around that particular piece, I think, too.
Does silence mean I'm not interested in your question, or does silence mean I don't have any response? What does silence mean?
I don't have any response. I'm taking it in.
Okay. You know, Larry, I do want to say that Riverside's going to be a little hotbed, because one of the large HIEs that are going to be getting a lot of funding are based in Riverside, and it's Manifest MedX. You really want to look them up and hop onto that bandwagon if you can, from a funding perspective, because they're in line for a lot of money.
Thanks.
Justin, what about you? What's your kind of approach to data needs, data strategy?
Well, just developing it, really. Then the analysts in our community-facing arm of the hospital, I'm just providing data basically to Restoration House and our collaboratives, taking care of our vulnerable population. So it's basically a population health and program needs-based data solution.
And I'm sorry, you're receiving it or you're giving it, the data?
I am finding it. Well, these are all internal to our hospital, and then because our hospital funds our collaborative, the Hope Rising Collaborative, we have access to data to be able to share. But that's a community entity that helps with our county health needs. We do have the other big player is Partnership. Partnership Health is the plan, and they share data to us because we're contracted with them. But other than that, I don't see any data coming from the other two hospitals sharing data.
Yeah, you know, I mean, when we talk about data, I think some people kind of hook into the conversation and see the value, and others kind of, it can be, you know, dazed and confused, and I'm not sure what the compelling, and I want to just kind of give a perspective on why it might be important. You know, from a development perspective, when you're raising funding or you're designing programs, setting priorities, to be able to articulate, you know, what the community need is from a statistical perspective, from trending data, from, you know, where the gaps are in services, all of those things just make a huge difference when you're trying to secure funding for a program. And when you're trying to prioritize a community that could have multiple needs, to be able to justify the needs. So, you know, there are so many good data sources that are out there, and I'm happy to share, you know, the ones that I have. In fact, I kind of was hoping to do that. But, you know, there are data sources where you can put in your zip code and they will talk to you about, you know, the vulnerable population footprint in your area. You know, what are the demographics? What are the challenges? And I know that to some degree the community health needs assessment does that, but I think, I don't know, Sue, if you want to speak to the value of the community health needs assessment in making that assessment for your community. But I guess my point is there's a lot of really valuable data sources that could be accessed to really help clarify your priorities and your strategy, and then make a really strong case for why you're pursuing the strategy that you're pursuing to funders. And I think that from my perspective, what I'm finding is, you know, as a data wonk, really, you know, somebody that kind of like, I'm really excited about this idea of linking clinical and social determinant data. But then there's always the question of who's going to use it, how is it going to be accessed, and, you know, is it going to land in the place where it needs to land to make the most impact? And I think that there are some communities, some organizations out there that have done some amazing work on aggregating data and trying to spoon it up for people, but I think that it's still underutilized. And I think that was one of the things that I just, you know, Sue and I have been talking about is, you know, is there any support that your group needs in accessing those data, understanding what data you really need and why it would be helpful, and then how to access it.
Mm-hmm. Well, the other thing too, I was thinking, Jessica, when you were speaking, some of the groups, you know, the ACHs have or are beginning to get a data committee or a performance management committee. You know, everybody's maybe calling them a little bit differently. And a couple of the sites, they're using that as kind of supporting the community health assessment or community health needs assessment. So it's a group of organizations who might have some kind of a data person who's coming together. And I think, you know, Jessica, I know you guys are doing a version of that. And as you were speaking, it just made me wonder just in terms of the need, because as you start to integrate different types of data sources, then the issue of what does all of that mean? You know, the meaning making of all of those things together becomes way more complex than it did if you were just like, oh, here's the obesity rate or the diabetes rate or, you know, whatever. And some of you know, you're all in different spaces and not everybody's on, but that's a huge need and issue, I believe. And just, you know, kind of wondering, you know, and some of you may not be able to answer it because you maybe haven't identified your goals yet because you're still working on that. But that's kind of just another thing, you know, Jessica, as you were talking, I'm wondering how that's working, if you see that as a need in your particular area, or if you feel like you got that covered.
I'll actually probably let Patty largely weigh in on this because she has been providing all the support to the data committee. I think we do have a data work group. I do envision that work group will be one of the sort of sense-making bodies about all the variety of data sources and also looking at what data sources are available for the sort of goals that we've set around our portfolio of interventions. They haven't functioned as much in that sort of way yet. And we do have, you know, like many of the communities in California community health assessment data and public health data that is pretty readily accessible to us. One of the things that we found around substance use disorder is that often there's sort of a varying set of metrics that all these different flavors of programs, prevention, treatment use to sort of understand or, you know, articulate their own efficacy, and that we don't really have consensus among stakeholders in our community yet about sort of measuring the impact of those programs. You know, each people use different sets of measures depending on how they're funded or, you know, their sort of value set related to their various programs. I don't know, Patty, anything else you would add to that end?
So I would add that we have in the public health department through the county an epidemiologist who is really wonderful at presenting and analyzing so many of the data that around substance use disorder. So that's really, it's really useful to have that in the community. There's that piece, and then there's the community health assessment. There's the CHIC survey. It's a survey that's, you know, administered to high school kids around substance use. So we have a lot of the pieces, except that I think that like maybe the meaning making part, it's like, okay, this information is all indicative of the problem that we have in our community, but then how do we act on this data in a way that we can identify some maybe short-term, medium-term, and long-term, progress. So that, presents a challenge because of the complexity of our subject matter, I think.
Right. Yeah, absolutely. And I think, Patty, you've done a nice job of gathering like the voice data, right? It's the voices of the people who are living on the streets, and that's not in an EHR. It's not, not there. And so I think that also adds to the complexity of, and I think helps it to kind of make sense of some of the madness with all the data out there.
Yeah, so. It certainly adds to the complexity, but it also sort of kind of, puts a human face to the like large scale data that we see. So the personal accounts certainly, clarify what we're seeing in a sense.
In this, another aspect of the data, it just occurs to me, Sue, that since we've got a little bit of time, I know that this group has been exposed to CACHI and the work that CACHI is doing. But it occurs, so, another program that Sue and I are working in is the Center to Advance Community Health and Equity. And one of the things that they are providing is community-based data analytics on community development activities, on social determinant information. It really tries to aggregate and get a picture of the community. And I think all of you received a sample report from that. I wonder, and the thing about, and it's striking me in this conversation, data is great, and everybody, we can all kind of get excited about good data sources, but it is kind of to what end, right? What are we doing with the data? What are we trying to accomplish? And with this program with CACHI, one of the things that they're working on is trying to use that data to better align investment strategy within the community, so that people are more informed about what the problems are and where the investments are currently being made, and where alignment can happen. Specifically with hospitals, or hospitals is a key part of the conversation. I wonder, do you remember the report that you received? And again, this is kind of in the spirit of understanding what data was useful and what can we learn about what we've done in terms of data analytics. So do you remember the report? Was it useful? And I guess another question I might also have is, do you have hospital involvement? And is that something that you're kind of pursuing as well?
Mm-hmm. So one word you didn't use, Catherine, is community benefit. So, you talked about community development, so that may, help to refresh the memory. It was, I'm trying to remember when it was, if it was like June, you each got a 2 or a 3 pager of the data, the community benefit data, and where those resources are being allocated. So.
Was that like years ago and we can't remember, or does anyone remember that information?
I remember getting it, but we haven't used it.
I remember getting it, Catherine. Hi, it's Jessica. So we have a unique dynamic. One of the things that's funding our ACH is through our community benefits department locally, their connection to the Wellbeing Trust. I think our feedback at that time, and I'm not sure I've sort of evolved in my thinking, is that when you have an anchor institution like we do in our community with the hospital and maybe a resource poor area, it's pretty uncomfortable to come in, especially when they have sort of a track record of funding things, and use that as a lever. I think that there's sort of a systems level of several steps above us, where there's maybe more of an opportunity to have that dialogue versus a sort of existing funded partner with our local sort of site. So I think that was our feedback at that time, and still feel much of the same way.
Yeah.
Wow, that's really interesting. I love, thank you, Jessica. That it's seen as a lever is, I think, a really interesting, that's interesting.
Well, it could be. I think the Fresno, it came up as well because on their leadership team, they have somebody from a hospital, and there's a power dynamic, because I think that's very present in the communities, whether it's named or not.
Right.
And so they were worried about that information being out there, and them kind of like, what's the response that would happen from a hospital? Now, San Gabriel, I know, has a totally different experience where they're very much in partnership, and the hospitals there actually are very transparent about that community benefit data. And then
Right.
Justin is from a hospital, and you know, so I can't speak to, you know,
Justin, yeah, Justin, did you see do you know what we're talking about? What that data report is?
I don't think that I burrowed into that one.
Okay. Okay.
So this is Larry. I just looked at the report, and the reason that we haven't made any use of it is that we have no relationship with any of those institutions, or we had not yet established relationships with any of those institutions. We were working with public health and the county hospital.
Mm-hmm. Those institutions being hospitals.
Hospitals, sorry. The report was about 5 or 6 hospitals. And
In
their
your community, yeah.
In Riverside, yeah.
Yeah.
I mean, they were part of another Accountable Community for Health coalition, but that has since imploded. So.
Mhm, mhm. Yeah, I mean, you know, from our perspective, and you know, you guys are in the weeds and frankly have to live the politics of it all, right? But I mean, if you look at, on the one hand, you've got the CACHI sites, you guys that are needing to develop wellness funds and, you know, sustainable business models, and you've got the hospitals who are all kind of having individual investment strategies, which may or may not be aligned with where the community is going. You know, what PHI is working on by way of both of these programs is trying to seek alignment in the investment strategies within the community. And I just wonder, does that resonate with you as an opportunity of bridging that? And I know I'm steering away a little bit, but a core part of that work is around data integration and around, well, not integration, but data and analytics, and, you know, presenting a view of the community in a way that kind of challenges some of the assumptions around where the funding is going and where the investments are being made. So would there be an interest in having some sort of effort to increase hospital participation in your organizations?
Nicole, I know you guys are in the midst, and the hospital, I think, that was participating before in the needs assessment now has chosen not to. Is that correct?
So we had previously partnered with some hospitals because they were also in the process of doing their community health needs assessment. So their needs assessment and our community health assessment kind of overlapped in time, and we were able to use the collaborative process, you know, each for our own needs, I think, in a way. And we've since gotten out of alignment with the timing, and I think that's been part of why we have kind of veered away from working with one another. But it would be really cool, I think, if we could find a way to certainly align our data collection efforts, because, you know, a big part of what we are doing right now with the CHA, the health assessment, is trying to present these social determinant of health indicators and keep them up to date for our county. And if there was a way to collaborate, you know, with our hospital partners and get some of that information from them, we would, you know, we have a platform within the county to kind of broadcast it to the public, essentially.
Mm-hmm.
So I don't know, I think it could be really cool if we could
Mm-hmm.
collaborate on something around this. We have data capacity in-house, but
Mm-hmm.
we're not necessarily in the field collecting that information. So yeah, if we could get a kind of an open line of communication going, or just whatever we might be able to do, I think it could be really cool.
Right.
This is Larry. At the convening, we talked with some of the people from San Diego and their 211 system. And I mean, that kind of a system, which took them, as he described, years to not only develop, but to get the agreements in place, that would be spectacular once you have interventions in the field and you have participants being able to have essentially a central database when you make referrals to community resources, to know whether they've taken advantage of them, whether they enrolled when they did, if they go for medical care elsewhere. All of that gets, as I understood it, as he described it, gets placed in the same database, or at least there that you can track individuals across these different services.
And are you saying Riverside doesn't have anything in the works, huh?
They didn't, whatever they have, they didn't share with us. So we don't know.
Okay. Well, so we've got 5 minutes left, and I just, I think this has been a useful discussion to really see where everybody is at different levels and working in different.
Mm-hmm. And Gina, I'm wondering, I see Gina joined. I'm just wondering if you have any comments or thoughts, or hopefully you have some audio. She's in Sacramento. She's got her microphone off, but Gina, any comments or anything on this? Because I know you guys are involved in somewhat in some data with the health department in Yolo County.
Yeah, Sue, this is Gina. Can you hear me?
I can.
Okay,
yeah.
Great. So, yeah, I mean, I think I've been kind of listening. I'm intrigued in this topic for a couple of reasons. One is, yes, we are involved in our county health department and hospital systems, CHA and CHNA, and we are using that information and data to help drive some of the work and our portfolio of interventions and kind of the action planning. So this is really an important topic of how to use that data and how to really integrate it. I am also, though, intrigued by this notion of, a shared platform or a space where all of the data is going in some way that's useful to everyone. I was just reading, I can't remember if it was something that was sent out, or maybe it was one of the webinars. I can't remember. There's so many resources with CACHI, but with this notion of having a place that feeds in all of the data in one place, and then linking, I think this conversation came up earlier, linking then with kind of social determinant of health data as well as resources. so that, whether it's case managers or patient navigators or, particular agencies or hospitals can actually use that data for, kind of getting it to the, people who need it or to the organizations that need it, basically making the data useful and usable. So that's kind of where we're at, is thinking about that and exploring that.
Yeah. Well, great. Well, so I guess I know we're just about out of time here. I don't know if there's any other closing pieces, Catherine, or any other comments or questions, or people would like to have more dialogue about maybe diving deeper into what really is data integration, like what's happening, maybe hearing about some of the use cases. I recognize you're all in different spaces. But sometimes it is good to just hear what's possible or to just kind of think about it. So yeah, any thoughts, Nicole, anything in closing?
I mean, I think it would just be really awesome if our local HIE, and I was kind of Googling them a little bit, and I'm not sure if they're on the slide that Catherine shared, if they're sort of have been.
So you're in Sacramento?
No, we're in Napa County.
Yeah.
And it looks like it's Connect Healthcare. So anyway, I don't know. I just think it would be really neat if we could collaborate, because we're really focused on upstream social determinants of health, and if we can, really kind of move the needle on at least getting the data and the information out there. I don't know. I've seen what 211 San Diego has done, and it's just so impressive. And I would love it if we could do something like that up around here.
Great.
Well, yeah, if anyone has any other questions or wants, to see about connecting to their HIE, the next 6 months is going to be big for HIEs in the state of California. There's going to be funding that's hits and some opportunities. So if you don't have a relationship with them now, I would encourage you to get one.
And one thing I'm wondering, Catherine, I don't know just in terms of like CACHI, or if there's a listing of the different HIEs to be matched up with the ACHs and contacts. I think, yeah, so Justin's asking, I think that might be a good resource to, at least to, as a next step.
So I just typed the web address for CACHI. I think it's cachi.org, California Association of Health Information Exchanges.org. You can find the listing of the HIEs there. And they should have contact information. You can find it, in your community.
Great. Okay, well, thank you. More to follow. Thanks you all. Okay.
Thank you, Sue.
Thank you, Catherine. Thank you.
Absolutely.